So record and hit that button. If you see, I think there's a button that pops up. And then give a round of applause, everybody. We're here. Unit 1, wrap up for MMOA Essential Foundations. We're 2 weeks in, but it's the first time we're meeting y'all. We're super pumped. Really good to see your all's faces here, but then also in the Facebook group as well. We got some more folks rolling in. Awesome. Lovely. All right, so here's what we're gonna do. We're gonna start off just with some general introductions so you have a better idea of who we are, just so we're not, some random individuals, that you're listening to via lecture and interacting with the Facebook group. And then we're going to go through some general questions, the assignments in terms of what themes that we may have seen that we want to speak to. And then we'll also get to the student unit questions, which were awesome, by the way. Thank you all for dropping those. Before we do an introduction, just some orientation in terms of Zoom, which we don't have to do this. This isn't as big of a deal now, but pre-pandemic, Zoom was a new thing for a lot of people, not so much anymore. But how we do this is we encourage you all to have kind of the Brady Bunch view. So it's the gallery, I believe gallery view on the top right corner of your screen. You can change that. That's usually a little easier to follow than the speaker view. And then also we really encourage conversation in terms of in the chat box, which there's a chat button that you can type in, but then also unmuting and speaking as well. In order to do that, in terms of unmuting and speaking, we encourage you to raise your hand via the function in Zoom. So not physically raise your hand, but push the button. I think it's under participants, somewhere around there. But look for that, and then that tells us, oh, this person has something to say or a question, and then we'll call on you. And that way we keep it kind of organized so there's not 20 some people trying to talk over each other, which is not too fun. All right, while we get into this, we would love to hear where you're from and then what setting do you practice in, whether you are in rehabilitation or you're in academia, fitness, whatever. Let us know a little bit about kind of what you're doing, the context of where you're working with older adults. You can just type that into the chat box if you don't mind. We love to see that stuff. All right, Christina.
Yeah, last thing too is you've seen that we've renamed ourselves. We've put our Instagram handles in the names. If you could put that there, then we can tag you in the course meetups and things like that, so that just so that we can follow each other and gain resources from each other through social media, connect even more. All right, so hello everyone. My name is Christina Previtt. I'm a physical therapist, originally from Ontario, Canada. I have just moved down to Charlotte, North Carolina in the last 2 weeks. This has been a long time coming, but I am in the process of moving my practice from Canada down to the US. I started in outpatient orthopedics, and I was getting into that classic cycle where I would have older adults, I would bring them into my clinic, we would be strengthening them, they would get their pain going down, their function would increase, we would discharge them, they would decondition for 3 or 4 months, and they would be back on my caseload. And that just didn't seem like the way that I wanted to run my practice. That wasn't something that lit me up. And so I started at a CrossFit gym. I've been CrossFitting for over 10 years now. And I was at a CrossFit gym treating, and I started a program called the Boomers. So basically I would discharge people from PT, and then I would allow them to, or if they wanted to, they could continue with like a group-based exercise program with me. And in that class, I ended up having a whole slew of different issues. We had people who were post-op joint replacement, people who were in post-op cardiac rehab, and it was just amazing. And it just seemed like a much better model. And so for that reason, I went back and started my PhD part-time, looking at the use of high intensity resistance training, getting barbells into older adults' hands on preventing transitions and institutionalization. So individuals with frailty, individuals with mobility disability, and trying to see if we can optimize function. And then from there, I started a business model that reflected that ideology. So Stave Off started 5 years ago. We were a gym physiotherapy hybrid model that looked into how to create a good continuum of care with geriatrics. My husband and I did that for 5 years, and it was successful. And now we're going to try and move that model down to the US. And that is why I'm here to start Stave Off USA. And that is a little bit about me. I'm also a mom of 2. I have an 8-week-old at home. 8 weeks and 2.5, keeping me busy.
A little bit, just a little bit.
A little bit. The toddler more than the newborn, I swear.
Yeah. The newborn's great. Toddler, that's. I'm not talking about mine. I'm just talking about that just from my personal experience.
Liam, Dustin, and I are all in that world.
Julie, who are you?
All right, what is up, everyone? So my name is Julie. I am in Charlotte, North Carolina as well. And I have been primarily in acute care and inpatient rehab for, 5 to 6 years. And when I started down here in Charlotte, it was a really awesome opportunity because I wanted to work with sick older adults and I wanted to work with athletes. My brother owns a gym here in Charlotte. And so basically I was taking all of the things that you would do with athletes, and I was bringing that stuff into the hospital to start getting those people who are super sick, interested in health, wellness, and kind of move them from sickness towards wellness and fitness. I just recently switched over to home health. So that has been a very interesting learning experience for me, still very new. I'm still learning the ropes and doing documentation all hours of the night. So that's been really cool to kind of be on the other side, coming from acute care and then being able to see what happens to these folks after they leave. In addition to that, I'll do private visits with older adults in their homes and working with a gentleman in his 70s who had a cerebellar brain tumor from before diagnosis through surgery, chemo, radiation, and basically up until the week he died, was really life-changing for me and just kind of solidified why I love this population. At the same time I was working with him, I met, quote unquote, like virtually, Dustin and Christina, found out about them and just how they combined just the fitness portion and just treating older adults in a different way, the way that they should, was kind of, it was just very eye-opening for me. And I realized that these were my people. And I taught my first live last October. So it's been a little bit over a year and it's been awesome. So yeah. And me and Christina may start hanging out soon here in Charlotte. So that'll be awesome.
Like Saturday.
Awesome. All right, Sam, tell us about yourself.
As he said, my name is Sam. I have always worked in very rural clinics. I currently work at Cherokee Nation in J America in Oklahoma. It's a town of about 2,000, so very small. And with working in rural clinics, I've always been pretty much solo. The first private practice clinic I worked at, we did have a couple other PTs there. One was very old school in their methodology and was very like yellow TheraBand and ankle pumps. Like it was very limiting. And if even as a new grad at that time trying to progress patients, she'd always like try to pull me back, like, oh, are you sure they need to be progressing that far right now? And I'm like, yeah, probably. But you know, you don't have that ground to stand on at that point when you're a new grad. So you're like, well, am I doing what's right? And then went and became a clinic director at another company. Also the only PT there. I had a PTA, so it was a very small practice. So I knew I needed some kind of mentorship, some kind of additional help besides your typical CEUs. And that's when I found ICE after I took my first lumbar course with Jeff, and then have just kind of been, as some people say, I drank the Kool-Aid, and I've been following it ever since. So taken quite a few of their courses and just really enjoy them and get to learn a lot from them. So then just trying to make that change bigger within my current population. I don't know how much you guys know about the Indian population, but very uncommon for me to get anyone that doesn't have diabetes and high blood pressure. Like that's just, I can pretty much guarantee that those two things are going to be marked on their intake paperwork. So lots of things that could be mitigated with exercise. And so trying to get that to be a part of the culture and part of the community, like expectation is really where I'm focused at. And then we have a local gym here that I recently talked to the gym owner. And so hopefully I'll just start treating just on the side there as well to try to get our mission out there and get people who are already in the gym that help so that they don't stop going to the gym just because of a little shoulder pain or a little knee pain that's bothering them. So getting that worked up as well.
Beautiful. Awesome. All right. Love what we're seeing in the chat box as well. We got lots of outpatient folks, lots of home healthers. I see some acute folks in there. I think I saw a couple sniffers. I think I saw an OT as well. Any other people jump out to you? Julie, Christina? We're seeing a pretty diverse group, which is an awesome thing. And that's really the value in this course. So you all will quickly find out as we start to discuss these things, that these people from these different settings start to share their perspective. And it's not that common for us to be able to mingle and hang with folks from different settings, right? I mean, some of you all have experience in other settings, but a lot of people don't. They go to outpatient, they kind of stick in that arena or whatever, that particular setting is. So this is really good. From our standpoint, when we see the diversity in the chat box, this is going to be an awesome cohort. That's good. All right. So real quick, my name is Dustin. I'm in Lexington, Kentucky. Any Kentuckians in here? I didn't see any Kentuckians. Oh, that's a bummer. Well, if you drink bourbon, any bourbon fans? I always say this. Yeah, there we go. Yeah, And Julie asked me what if I was drinking. I'm drinking decaf tea here, Julie, by the way.
I'm
not bourbon.
Disappointed.
Yeah, but I'm in bourbon country, so bourbon.
Chris is like giving you the thumbs down.
Yeah.
Negative
Nick
review.
is yelling in the background. Yeah, I'm a bourbon fan.
Yeah. Yeah, that's well, we have a funny story for that. We'll save that one for later. So yeah, that's where I'm at. Fast horses, good bourbon, Lexington, Kentucky. A lot of my experience is in home health. Really love that arena, that setting, and it really formed a lot of my perspective of how we can serve older adults. Mix that with a background in kind of orthopedic strength and conditioning, similar to a lot of the people that you've heard from already. And I really became very intrigued and interested in how we can better serve older adults. That interest was also paired with the realization that many of you all see on a day-to-day basis of how older adults are severely underserved across settings. And that has really driven me to become more curious how we can better serve folks and to talk about it a lot on social media and with people like you. So currently with Jeff Musgrave, another TA within MMOA, doing Stronger Life, which is a fitness program housed within an existing CrossFit facility in Lexington, very similar to what Christina was doing in Kenyatta, Canada. Sorry, not Kenyatta, Canada. All right, that's enough about me. Let's get into this, okay? So who was super nervous? Raise your hand if you were super nervous to film yourself and post it in the Facebook group. Some, I'm gonna be honest, it can be intimidating. Yeah, we get nervous. We still get nervous, but bravo to y'all for doing that. The week 1 assignment, we know it was silly. We did the tug challenge. We had a good time. The main goal of that is just to really get you to think differently about outcome measures, but then also to get used to kind of filming yourself, because we're going to do a lot of that through this course. It's also going to pay off down the road as well. When we start, especially when we get to week 8, when we talk about how to be advocates for older adults. So bravo to y'all for participating there. So when we talk about a lot of these outcome measures, raise your hand or you can type in the chat box as well. How many of you all are already using some of those outcome measures that we talked about? Those functional outcome measures. A good bit, right? What about in the chat box for those that don't have their video on? Yeah, lots of hands raised. That's a good thing. For some of you all, you're forced to, right? Raise your hand if you're forced to take some of those outcome measures. Yeah, which is very common, especially home health, pretty common, SNF, pretty common, outpatient, not so much. So we want to introduce these in kind of a balanced manner for those that may already be using them, but to think about them in a different light, but then also for the outpatient clinicians that may not necessarily have to use them, but to try and leverage those to gather good information, but also to allow you to allow that to kind of direct your course of care and really demonstrate your value to people. So we're going to dive in a lot. We're going to talk a lot about these outcome measures, especially with these assignments. We had a lot of questions related to these outcome measures. So I think a good plan right now, Julie, is if we kind of go into some of the assignment themes, and we'll hit some of these questions as well. And anything that we don't hit, we'll have time for some discussion after the fact. All right, you're co-host, right?
Yeah.
Yeah, you're good to go.
All right, let me share my screen. Okay, so we first have to watch the tug challenge winner. All right, that is first and foremost. So is Melissa on the call? I can't see everyone. So if she's here, this is a moment of glory because this is amazing.
She's not.
Darn. All right, here we go. Boom. Bam. I think she was 3.21 seconds. That may be a new record or very, very close to a new record. We did have a very close second, which we're going to watch because it was 3.21 versus 3.24. So we got to watch this one as well. And look at that stride already. My goodness. Okay. Like ready to go. Let me back it up. All right. Whoa. Amazing. The long strides are where it's at for sure. Okay, now we have a style point winner because we have to have a style point winner, right? So we are going to watch Curtis because he did this awesome like backspin and it was just amazing. So let's watch this.
He's giving us the fist pump.
Look at this. Look at that. Beautiful. Beautiful. So everyone give a round of applause. First place, second place, and style point winner. Okay, let me. Okay. Okay, so if we talk about themes with these outcome measures, so let's first talk about standardization with these outcome measures. So if we are going to use the normative values, if we are going to use the cutoff scores, we have to be doing the tests in exactly the way that they're instructed, right? The problem is that in many settings, obviously, we can't standardize. It's just not possible. So if we're thinking about home health, folks, we may not have 10 clear feet whatsoever. We may not have a standard chair. So just to give you guys like a example today, I show up to my patient. He is standing outside, running around, holding his oxygen tank. He has lost his cat. So we have to try and herd the cats, right? By the time we go inside, I'm sitting him down. I have to do a tug on everyone for home health. It's required by my company. This guy I know is going to blow this tug out of the water. He just ran around his yard with his oxygen tank in hand, frantically trying to chase his cat. Like I know that his tug is he's going to blow it out of the water. He refuses to do the tug without holding on to his oxygen tank. Because he said, if I am up on my feet, I am carrying this oxygen tank with me. It wasn't a full, it was like it was a mini one. So was I going to fight with him? No. If that's going to be what he's going to be doing every single day, then we're going to do the tug with the oxygen tank. Now, again, it's not something that I can use cutoff scores and because clearly the instructions do not say to do it holding on to an oxygen tank. However, that is still something I can show him, knowing that he blew it out of the water, that I can just say, hey, like clearly, like per this test, you're not at risk for falls. This looks awesome. Let's challenge you with something else. So I know you guys have probably experienced not being able to standardize these tests. So if anyone wants to chime in and say like what you do in a situation where you can't standardize, or any like patient story that you have, like we'd love to kind of hear how you approach that situation. And if anyone, like Sam, if anyone's raising their hand, if you want to like call on someone, since I'm not staring at it. Basically.
Shy group, no one wants to talk.
Break the ice. Someone
Break
do
the
it.
ice,
Pull the Band-Aid
guys.
off.
Break the ice.
What was your question again, Julie?
Yeah. So how are you guys approaching the situation if you can't standardize a test, right? So if with a tug, you don't have 10 feet of open space, if you don't have a chair at the standard height, how are you guys dealing with that situation with your patients?
A couple people in the chat are saying that they're going to note the changes. What do you think are the important variables to mention in your notes? Yeah. Gavin / Lindsay.
Note what changes.
Yeah, get Lindsay.
Can you hear me?
It's kind of choppy.
Okay. So I think one of the most important. Okay.
I'm gonna turn your video off.
I can just type in.
Now try.
One of the. So one of the most important variables to note, I think, is the chair height, and that's always hard to standardize. So an outpatient, you know, they don't come in with if they come in their wheelchair, then that's easy to know, you know, that it's from a wheelchair. But if we have them do it from a mat or one of our chairs in the clinic, I think that, and that's such an important part of the test, is if the mat is too high or the chair's higher than normal, then it's going to be a lot easier. So I usually just try to note about, you know, what their knee flexion is in the chair, you know, how high it is or how high the seat height is. But I'd say that's in outpatient, we have the space. So chair height's usually the big variable.
Yeah, absolutely. And many patients, again, they don't have the perfect standard chair, and in home health, you know, they're sitting there in their recliner. That's like the only chair they may have. That's the only one they want to sit in. So some other people mentioned just noting the consistencies there. So in flannel patterned recliner, using bilateral armrests in the living room, right? So just trying to be as specific as you possibly can so that you can keep that consistent from session to session. And also, if another therapist is following you and is going to be redoing an outcome measure, they have to be able to know exactly how you did it, what room they were in, what chair they used, so that you can have a valid score there from time to time. So just being as detailed as possible.
Yeah. How about things like ordering of the test? If you have 6 outcome measures, say that you have to do for somebody who's homebound, and they're all requiring certain amounts of a lower extremity strength and they're 1 rep max living, do you think if the tug was 1st versus 6th, that would matter, or we should be documenting that? Probably. And in our live course, we do a 2-minute step test, and we make you giver with the 2-minute step test. And then we try and say, would you want to do a tug or a 30-second sit to stand after this, after literally doing a 2-minute sprint, which for our clients, you know, you're like, well, my client isn't sprinting, but relatively, it may feel like the same level of exertion. So important things to be considering is, ordering for some clients, especially neurological populations. You're thinking that the time that you came and had your appointment, like if you're in an inpatient setting, were you the third allied health professional and that person has seen SLP, OT, and now they're seeing you and you're running a whole battery of tests after the SLP has done a battery of tests and the OT has done a battery of tests and the nurses have gotten you up and go to the bathroom. Like all of those things can be super, super important and are going to really influence the results on the outcome measure. And this is even more important if this is happening on your your discharge eval, right? Because if all these things are coming up, then it may not show the true improvement that you're looking to get, or that you've seen over the 6 or 8 or 12 weeks or however long you've been working with this person.
And some other things, in terms of, and you guys have had a lot of good questions and a lot of your videos had these comments and really good discussions. Some of the nuances. So, if we think about tug, you're starting with the back against the chair. The instructions are kind of ambiguous. It says turn around at the line, right? A lot of us sometimes are like, oh my gosh, I've been using like a cone the whole time, and turning around a cone versus a line, like that's going to make a difference in how long it takes someone, right, to turn around in a line versus having to turn around an object. For the SPPB, it says for the gait portion, you have to have a foot across the line. So just kind of taking into consideration the tiny differences between these outcome measures. Sam, did you have some other things that you saw on the assignments?
Yeah, so there's a few things that kept coming up. One was, of course, having the back against the chair. And in the tug scenario, of course, we're like ready and anticipating it because it's like a fast tug, right? Your patient's probably not going to be quite as gung-ho about like trying to get up as much as you are trying to get a super fast speed here. But you just want to make sure that they're starting with their back against the chair. Another one of those, just standardized, make sure that each of those little things are marked. It doesn't seem like a big deal until you're really trying to point out that they're making a difference, when you go to retest. So if they start out at the edge of the chair the first time you do it, and then they start with their back against the chair the next time, then they might have a slower time and they think they're getting worse, when in reality, they just started different and it's harder to get up from their back being in a rested position. So that's something to be aware of. And then I pulled a couple up here. Let me see. On the SPPBs, there was some really good examples of like things that you will see. So who was it? Let me see. Carolyn had a really good, she did a good gait demonstration. She had a step 2 gait. So even if someone might not have a improved gait speed, you might make that note on your documentation that they had a step 2 gait before, and now they have a step through gait. So you can at least have something to celebrate with them, something to show that you are making improvements, you are decreasing your fall risk with these little changes that are very functional for you. So that was like the main things that I saw.
Cool.
Awesome.
Sweet.
I wanted to talk quickly to Kelly's point. Kelly said, I try to remember that just because something is the protocol or the rules, this may not be functional or something that is possible for the patient to do. So there are a couple of things I think to unpack there. Number one is, some of these deviations that we were talking about, like if we're doing a 5-time sit-to-stand test and your arms are supposed to be crossed over your chest, and your client can't do a sit-to-stand without use of upper extremity assist, they would basically be unable to complete a 5-time sit-to-stand, but I would still get them to do a 5-time sit-to-stand with upper extremity assist to get their baseline. We just know that sometimes we can't use it against the normative data because there's no translation. The second thing is that the protocols, the way that they're written, it is really important that we try to stick to them as much as possible because of the decision making that we are using when we are using these outcome measures. So if we are using a cutoff score on the TUG or gait speed or the SPPB to make clinical decisions about risk, then we are using normative data created based on a very specific protocol. When we are doing, like, for example, going around a cone versus a line, we're navigating an obstacle versus pivoting. Those are technically different skills. And so from a cone perspective, you may have an inflation of 2 or 3 seconds on the timed up and go, which may not seem like a huge deal if you're being consistent. But if you're using the 12-second timed up and go cutoff score for identifying a person as a falls risk, and that 2 seconds changes them from an 11 to a 13, you're labeling potentially an individual as an increased risk of falls when they probably wouldn't be if you went by the protocol. So the normative data and the statistical cutoff scores are based on, you know, these feasibility and validity studies that have been completed on a specific protocol. So it may seem very nitpicky, but in order for us to make true prognostic or risk stratification decisions based on these outcome measures, we do have to try and be as close to the protocol as we can, or recognize that there is going to be a little bit more gray area in terms of how much we can use, especially a single outcome measure, to make clinical decisions if we're really outside of the way that this study was validated. Yeah, Lindsay, exactly. The cone, especially as time for patients with hemiparesis or prosthetic limbs and those walking with walkers, absolutely. And some motor neurodegenerative conditions too, like that can make a huge difference for them.
Sorry if I get your name wrong, but Anushka, close? Not anywhere close?
Yep.
Sweet. She brought up a good point with her SPPB2 also, is that she showed that it was difficult to walk at that slower speed. So when we think about how slow someone's walking and why that matters, I know there's been several research articles on it where gait speed is kind of like that additional health measure. Like it tells you a lot about kind of like grip strength. It just tells you a lot about where someone is fitness level wise. So imagine someone that's as fast as they can walk. Like how's their overall health? Like it gives you a really good picture of what that person's health might be just by how fast or slow they're walking.
And guys, if you think about, like, just to kind of piggyback off that, like why it's so important to do outcome measures and why it's so important to do outcome measures, not just on eval. So if a lot of you are like me who follow other therapists, like I was PRN in the hospital, so I was meeting strangers every single day. I was going from facility to facility, and trying to come up with a plan to do with every single patient is completely, entirely exhausting. I learned over time that one of the most beneficial things I could do is actually not do exercise, like not jump right to what are the TheraX and their flow sheet that I can do. Maybe one of the more beneficial things is to just kind of start over with the patient and redo that outcome measure that they probably haven't had done in weeks. So if you kind of go back and you do the outcome measure with the patient, and then you can stratify risk again, you can show them their score, you can tell them how they're progressing. That sometimes can be so beneficial because you may come in and be the one therapist that looks at their score, does the outcome measure, and realizes, why are we even working towards this? Do their goals reflect? Is this too easy, too hard? Is there a different one that we should be using? Does this now give me specific exercises I can suggest to the next therapist to work on? So it can be a really powerful way to kind of reset with that patient and set them down a better path versus just coming into the patient and let me just see what the TheraX flow sheet is and just autopilot doing that. So just a thought, because I used to operate where, well, I want to get to exercise. I want to get to exercise. I don't want to do an outcome measure. That's not helpful. And I think it actually can be incredibly helpful and even more helpful sometimes than going right to exercise.
We had an interesting comment That was a good point, Julie. We had an interesting comment from AgeRight. We found when we implement SPP on every patient, it changed the intervention focus of therapists from ambulating patients to working on their strength. We found they were treating to the test. AgeRight, would you be willing to unmute and just speak to that situation?
Hi, yeah. So we rolled out the CGA across the subacute campus, and I would have done the SPPB on thousands and thousands of patients in that time. And we found that doing the research project and enforcing a SPPB to be done at the start of their admission and again at the end of the admission, it changed the way that therapists were treating their patients. So it changed more than me talking to therapists in services and things like that. They were seeing that if they treated strength in their treatment rationale, they got better outcomes. Like it was immediate feedback after 20 days of hospital admission. They kind of go, hang on a minute. Just walking the patient is not cracking it. But if I do loads and loads of squats and hinges, I'm getting good results. So I want that mode. And I didn't have to say anything. I just had to train them up how to do the SPPB, and the rest took care of itself. Yeah, it was mind-blowing, actually.
Yeah. Especially, I think too, like how there's lots of factors, right? Like you could introduce it to them, but I think also how you may be presenting it or how it's leveraged in the documentation system is another factor. So for some of you all that may use SPPB, you may not have the norms built in, or you may not have the different categories, and you may be using the SPPB calculator app. But a lot of systems have this built in. And I worked with a home health agency that you would put the number in and it would show you, it would automatically spit their number out, but also give the references in terms of the normative values. And it made it very, very clear to me without even having to put an ounce of energy towards remembering any cutoffs whatsoever. It made it very clear, this person has a deficit here. We need to work on this area. And that greatly influenced me and many of the people that I worked with as well. But you run people through this and it will be very clear, depending on your setting, right? But it'll make it very clear what you may want to work on. It'll limit the guessing for sure. But I think this question too, in terms of what Julie was talking about, of like the timing of the measures as well, especially like on the first day and then following up with someone after the fact. We had a good question that kind of speaks to this. Tim, is Tim on the call? Let's see. He's not. So hello, Tim, on the recording. Tim said, steady versus SPPB. Has there been research to compare the two measures? Is there one preferred over the other for the outpatient PT doing screening for someone who comes in for low back pain? I asked them if they're concerned about their balance or falling after seeing them navigate the clinic, and they say yes. So the first answer to that question is no comparison that I'm aware of in a recent check, which was about a few months ago. But this brings up the good point of when to do some of these functional outcome measures. In home health, or many of you all where you're forced to do these outcome measures, it can be a challenging situation, right? Because many of your folks on your caseload, as I could speak for home health at least, many of the folks it's not necessarily pain driven, right? You're not treating a ton of pain. Yes, there may be some pain on board, but the main reason for that referral is usually related to what? A fall, functional decline. They need assistance with some type of activity. And so you can knock out outcome measures typically early on and not run the risk of elevating someone's irritability to a detrimental level. However, people like Tim, a lot of people on this call in the outpatient arena, you have someone that comes to you for low back pain, highly irritable individual, and that's their main goal, right? They want to reduce their back pain. And then you run them through about 3 or 4 outcome measures. How do you think that's going to go? Are they going to enjoy that? Just give me a thumbs up or thumbs down. Yeah, not so much, right? No middle fingers. They'll probably give you a middle finger, but yeah, thumbs down. Yeah, that's a really challenging situation. And I'll raise my hand. I'm the first one to admit that I've definitely been guilty of this, where I've over-examined a highly irritable individual, where I knew these outcome measures are important. I'm going to run them through all these tests, despite them coming to me for their low back pain. And what happened? Next visit, no show, cancellation. Oh, I had something pop up. You know, everyone's kind of been in that spot. So we have to be thoughtful about when we apply these outcome measures. And so someone's primary goal is reducing their irritability. That needs to be our primary focus as well. However, we are going to plant the seed of looking at these other areas that can improve their lives overall, not just their pain, but their lives, their quality of life. And so this is where, for Tim's specific example, we may not run someone through the SPPB. We may do some of the study where we ask them some of these questions. We may ask them some of these other questions looking at these other variables. Probably not though, because they really care about their pain. But these are things that we can dive into as their irritability goes down at subsequent visits. So when we can apply these is really, really important. For some of you all, this is a bigger issue, like the outpatient clinicians, than someone in home health, for example, where irritability is not the biggest problem for a lot of individuals. But it's something that we want to think about. Has anyone else been guilty of that, of running people through a bunch of outcome measures to gather data when all that person really cared about was getting rid of their pain? I'm the only one? Wow, man, I'm the worst.
You guys are going to notice that most of the reasons why we teach half of the things we do are because of mistakes that Dustin and I have made in our practice.
Yeah. Don't do this. That's all we talk about. Yeah, there's this one time, so y'all probably shouldn't do that. That's what you're going to walk away with.
Yeah.
Okay, awesome.
All right, one of the next questions is around gait speed with the SPPB. I love this question. We try to bring this up every time we do this meetup. Why or why not can you take the gait speed question on the SPPB? Can we use it to extrapolate a usual gait speed? Yes or no? Yep. Yeah, Michelle's got it. So the answer is no. We cannot. And it's because when we do a usual gait speed, there is an acceleration and deceleration zone. So you're getting a true measure of their speed, usual gait speed or fast gait speed. And with the SPPB, that's already kind of factored in. And it's why the anchor points for each level on the SPPB between 1 and 4 are actually much lower than some of the 1.0 or 0.8 meters per second that we're seeing as some of this predictive, that has a high predictive power for different functional outcomes. Yeah, perfect. The next one is, maybe I'm being nitpicky, but the instructions from the geriatrics toolkit has the clock stopping once the participant has stood for the 4th time, but this article has the clock stopping when the participant sits for the 5th time. So for the SPPB, it's when you stand up for the 5th time. But make sure if there's any deviation that you are just documenting what you've done. If there's any inconsistency across, especially if you're not the one doing every test retest, you want to make sure that you're either documenting that if you're not having discussions with the person that's going to be doing the reeval, or having a conversation with them.
And the sit to stands can get tricky, right? Because like the SPPB 5 times is standing up on the 5th. If you just search 5 times sit to stand test, it's when their butt hits the 5th. If you do 30-second sit to stand test, it's when they've stood up. That's the last rep that you count, or at least halfway. So there's a lot of nuance when you start the clock, stop the clock. All these little nuances that we've talked about, that you don't want to sleep on them, for sure. You want to be pretty aware of some of these changes, especially if you're going to be using them to compare and identify if they are below kind of a normative cutoff value, or demonstrate, your value or reason for your services to a third-party payer. It does seem nitpicky, but important.
I love Tracy's comment here. Some clients think that the outcome measures are more interesting for the therapist than for them. That is such a good point. And it's all about how we are presenting this to our patients, right? I mean, probably a lot of us have started with the research says, or we know from research studies, and maybe we show it to them. I mean, I've done this wrong a million times and it's wasted so much time. They don't care. They're already completely overwhelmed by, if it's on home health, how many therapists they've seen that day or that week. And acute care, they're in pain, they're sick, they don't give a crap. They're like, how do I get home? It's really about how we present this. And it's hard because we have all this knowledge and we just want to talk and kind of get out all this knowledge. But really that can just be like, hey, we're going to do a test that looks at the strength in your legs. And that can be it. Or if you are going to do it and it's standardized and you're going to be able to use normative values, you can say, you know, hey, other folks who are your age, who are living out in the community, this is how they're doing. And we want you to be able to stack up just like all of them, your neighbors who are here and who are living independently. Like that's kind of a script that I've been using recently. And that can be really effective way to introduce it where they're not completely confused, overwhelmed, or they just like don't care. Does anyone else have any other ways that they've presented outcome measures that your patients have, you know, really bought into, or they've kind of just understood what you're going for and they're not overwhelmed? Any wins there? My patients love to see their outcome measures. I only do them every 6 weeks, so they usually have made good improvements. This is in private practice. Yeah, guys, patients actually love scores. Older adults still like to keep score. Maybe at first they're a little like my patient right now is like, she tolerates me. She doesn't want to do any of this, but she tolerates me. But now she actually is like, you know, she gets ready to go when we're doing like 30 seconds sit to stand. She's and you tell them their numbers and they start to internalize that. So don't underestimate that just because it's not an athlete in a gym that older adults don't like to keep score. They totally do.
What
Julie,
I
I
love
think
is,
that's another, sorry, Dustin.
no, you go ahead.
I think that's another spot where we tend to mess up is we know that we care about the scores, but we don't always convey those scores to our patient and what they mean, like outside of saying the research shows, but like, oh, you scored this. Well, that first time it might not be that relevant to them, but you do it again in a few weeks and you said, hey, this time you scored this. And they're like, oh, I did a lot better. And then you get that competitive drive, like, oh, I have something to work for. Like they start to see why they're doing it. And then another way to just present it to them is we're just going to see what we need to focus on first. Like, we don't want to waste your time. What do we need to focus on first? So if you're checking balance, sit to stand, and gait, and you're letting them know, like, this is where you show the weakest. So we're gonna really work on this week. Then that kind of gives them some buy-in to why are we doing all these random tests.
Mm-hmm.
And I think too, the value of using a measure that you think they're going to score well in, compare the norms where they're normal compared to their peers. That's a potent, powerful moment, especially for someone that's been through the medical meat grinder, been told everything that's wrong with them. They've got the 1520 ICD-10 codes, 1520 medications, all the issues in the world, right? Nothing is right with me. I am broken. And then you run, it may be something like a grip strength and they show to be normal. Just watch their eyes light up. And that can be powerful. And then, you know, do some of these other screens that are likely going to show deficits, but I think we want to highlight where they are considered normal for many folks. So they don't perceive that they are, but they may be in some facets.
Lindsay made a good point in saying that these outcome measures might be harder for individuals or less productive with individuals that have progressive conditions. And in that case, it might be that maintaining might be like the goal, or saying, you know, like you've kept it at the same level. Yeah. And Trish said with progressive disease, it's always important to set clear expectations from the start. And that's so true. And I think that also depends on the mindset too, and how a person is dealing with their diagnosis, or how fresh that diagnosis is, how, you know, they're doing from a mental health perspective, because, you know, there's a grieving process to being diagnosed with anything neurodegenerative or anything progressive in nature. And so, you know, having those conversations and kind of getting an idea of where your client is at from a mindset and mental health perspective, I think, or the stage they are in terms of accepting their condition can be really important.
And their caregiver and support system.
Yeah.
That too.
One example that really pops out to me, I know we're getting close to the end of time. I had a client I was working with in spinal cord injury as a student, and he was in his late 70s, was very, very active, went in for a AAA repair, and they nicked his spinal cord. He ended up being a complete paraplegic. So it was an error. And so he thought he was going in for a routine surgery. He ends up not losing control of his legs, and he only wanted to walk. So he was an outpatient SCI rehab. We were trying to teach him wheelchair skills, and he was like not having it. Like he was like, nope, that is not what I want to do. And so any of those outcome measures that we're not trying to get a gait assessment or a muscular activation scale or some sort of idea of how much new muscle movement he had, he wasn't interested in. So that just kind of was one of those things where it wasn't really productive for us to try and do anything like that. So that's kind of that story always stuck with me. We have two more questions. So Park asked in the group, any factoring of leg length for the CVC or SPVB 5 times sit to stand? I had a CI indicating that you should pick a seat height that gets their thighs close to parallel to even the playing field for the SPVB. I know the CVC test is 17 inches height or seat height. I don't believe the official SPV instructions indicate a height, but I saw one that was 18 or 19. So it's definitely going to influence if you're a lot taller, you got a lot farther to go for a sit to stand from a standard height, but the normative data does not take into account or make any adjustments for height. The only test I think that I know that has an adjustment for height is maybe the 2-minute step test, because it takes a knee height indicator. I don't know if there's any other, can you guys think of any other outcome measure that does that takes height into account? I don't think so.
No.
There's sometimes gender norms, obviously, with things like growth strength, but yeah. Justin, did you want to take the last one?
Yeah. Is Park on here? Yeah, awesome. The question, in regard to the study screen, it indicated that vitamin D supplementation may be beneficial. Seems like it helps with both calcium regulation to reduce fracture risk and postural control to reduce fall risk. Is that something we should be mentioning to our patients, or is that outside our scope? If it is outside our scope, should we be communicating with the referring provider to consider it for their patients? This is a great question. Some of you all are going to be in these scenarios more than others, I think, in terms of consistently looking at supplementation. I would throw in medication as well in this realm. And so within our scope, we can definitely speak to these things. We cannot make recommendations per se of what they should take or should not take, but we can discuss them and then also make an informed referral to an individual. So this is where you want to be very careful, not say you should be taking this supplement, you should be doing this, this, and this. Especially in the context of, let's say you're a home health clinician where you've got lots of people on board. You have people that are running point, or they're the lead in kind of managing that area. For the basketball fans, I say running point a lot. And Christine's always like, what are you talking about?
I know that.
Yeah, you're going to have someone on that team likely that you want to lean on them and kind of refer that question to that individual. But our main role here is to screen, identify if there is a particular issue or deficit, and then communicate that with a referral source. That is our main goal, and that's what we're advocating. But that's not to discount our influence in influencing their behaviors around these things. But our main role is to screen, identify, and then be able to connect them, especially when we're talking about some of these supplementations and medications.
Yeah.
What do y'all think about that? Do y'all have any differing opinions or any experience with that? having some of those conversations about supplements and medications and whatnot?
I tend to stay away from the supplements question just because, you know, I wouldn't want to recommend a supplement and there's an interaction with one of the meds. The one that I will touch on a lot more is I ask a lot about nutrition, because protein is generally so low in my older adults. And so I will touch on, you know, boosting up their nutrition or their protein in some way, or water. I have a lot of clients who don't want to have, yes, and Curtis direct messaged me, said if you're an RD in the hospital, like you have access to those individuals, which is amazing. In private practice, I never did. Hydration too is a big thing for older adults. They don't have the same drive for thirst, so they're not going to feel dehydrated as quickly, or they're dealing with, yes, they're dealing with urinary incontinence, and they think that if they drink less water, they're going to leak less, and that's actually not the case. That's a whole other rant, but definitely something to dive into that might be influencing our outcomes.
Yeah, I think we can really encourage their interest as well, especially if they're like hearing some of these things from other people of like, oh, I never, you know, someone else said that nutrition was important for my strength and independence, or protein or creatine or whatever, you know, supplementation, that we can be that other voice as well that may convince them, okay, I'm going to do something about this because I'm starting to hear this from multiple providers. Yeah. Awesome.
I just put an article in the chat. Actually, Dustin, you posted this like in our research chat like a while ago about vitamin D. So in those with sarcopenia, vitamin D and protein and rehab kind of being like a potent combination. So if you guys want to check that article out.
Yeah, you see more. What's that?
Sorry.
It's a free
frailty
free article.
Yeah, a frailty literature is pretty consistent with that too.
Yeah, there's some really interesting studies. It's the theme of a lot of folks, especially in like these controlled environments of different, you know, higher level rehab facilities where they're kind of controlling their nutrition and able to kind of systematize their rehabilitation, that they're able to show that, you know, if the rehabilitation is consistent and they're able to supplement with protein or creatine, they're showing some improvements in some of these outcomes, which is kind of interesting. So yeah, we definitely want to speak to these things. We don't want to ignore it. But likely we're identifying, screening, and then making a referral, but hyping up how these things can be definitely helpful for them. So cool. All right. 9:02.
So fast.
My gosh. I just heard my 3-year-old daughter who's not in bed yet. So this is going to be fun. So, but we try to be respectful of your all's time. So we like to end things right around 9. So this is a great start, y'all. We have a good group here, lots of different perspectives. And so it's going to just get better and better and better. What do they have to look forward to, Christina, for Unit 2?
This is where we're starting. I was going to say, Dustin, are you sure you don't want to stay on here a little bit longer? So Unit 2 meetup, now we're getting into the meat and potatoes of exercise prescription. So we're talking about risk versus reward, and we're going into the squat and deadlift labs. You're going to be filming yourself as well. With the videos, we want to see you all add some load. So we encourage you, because there's going to be 2 parts to the assignment. There's going to be you showing a deadlift and then you showing a deadlift variation based on a different musculoskeletal issue. We want to see you lift the weight, because oftentimes the issues with our form come up when there's load applied. And if we're going to try and get our clients lift heavy, we want to try and be lifting heavy too. So if you have access to some equipment, we would love to see you load it up. If you have any questions in the meantime, where this is kind of like the fun stuff, we go into finishing up Squattober. So that means, Anushka, you can have a huge squat to be showing us. You're going to be showing all the plates, putting us all to shame with these labs. So if you have any questions in the meantime, let us know. But this is always the fun part. This is what we love geeking out about, is the exercise prescription piece. We're going to be doing that over the next 3 weeks. And so our next meetup will be November 10th. So if you have any questions in the meantime, make sure to use the doc, use the Facebook group, tag us on social media, and we would love to keep these conversations going. This was awesome, so fast.
Yeah. Okay, awesome. All right, y'all. Lovely night. Talk to you soon.